Good afternoon. Welcome everyone to TCTAP Workshop 5, Tavr. I am Alan Young from Stanford. I'm joined by Sushil Kodali, and we have an extremely experienced panelist. We have Dr. Tavr, Dr. Hayashida, Dr. Wang, Dr. Wood, and Dr. Cole. We have two exciting segments. The first one is Tavr for bicuspid AS, which we have 3 lecturers, and then we will have a interactive discussion with all 3 lecturers. And the second segment will be on complex Tavr, and similarly 3 lecturers and then 1 session for discussion. So without further ado, we're going to start with our first lecturer on the Tavr for bicuspid AS. Something that we all really want to learn and master is really a bicuspid aortic valve imaging classification for the Tavr. So the lecturer is Dr. Hassan Jalahawi from NYU. Thank you, Hassan.
Thank you. Thank you, Dr. Young, and thank you, Dr. Park and the organizers for this kind invitation. So this is a very hot topic in our field, and I'll put to you how a classification framework may help guide not only clinical practice now, but also research in the field moving forward. These are my disclosures. So this is the classification that I will discuss. In the past, we have had several attempted classifications for bicuspid valve disease, but this framework was the result of a multi-center study led by Drs. Yoon and Makar from Cedars-Sinai. And we participated in this study of more than 1,000 patients. And they looked at outcomes based on morphology, and they identified risk groups. I'll show you very briefly the data from this classification, but the classification basically separated 3 potential Tavr risk groups. A low Tavr risk group where there was mild leaflet calcification, and in the case of type 1 bicuspids, either no RAFI calcification or no RAFI at all. An intermediate Tavr risk group where there was one of either excess leaflet calcium or RAFI calcium, and a high Tavr risk group when there was a combination of severe leaflet calcium and severe RAFI calcium. I would add to that from seeing cases in China with Professor Wang and colleagues, another potential group of circumferential calcium, regardless really of type 1 or type 0, that could potentially be a high Tavr risk group. So this was the data they looked at. So they looked at a low Tavr risk population, and they looked at these 3 morphology classifications, and they found a much higher risk of adverse outcomes. This was all-cause mortality at 2 years. And it was far greater with the high Tavr risk group, and fairly similar in the intermediate and low Tavr risk groups. This was important data. So not only that, but the high Tavr risk group here shown in red had an excess of pretty much all the serious complications, not only mortality, but also vascular complications, root injury, and mortality, as well as paravalvular leak. So we use this classification now routinely. So in our NYU Heart Valve Clinic with Matthew Williams, myself, a team of cardiologists and imagers, and so other surgeons, we look at each case, we look at the morphology, we look at the context of the Tavr risk, which has a known framework of the STS score, as well as other clinical factors. And then we compare that to the Tavr risk. We also look at additional surgical considerations, such as what is the CAD status, what is coexisting valve disease, is there aortopathy? And we put that together and we say, very simply, what is the Tavr risk? Is the Tavr risk intermediate, low, intermediate, or high? Is the Tavr risk low, intermediate, or high? And we should not do Tavr if the Tavr risk exceeds the Tavr risk. So we still adopt this framework even now in the clinic. We debate on the imaging, is this patient actually high Tavr risk? Is this intermediate Tavr risk? But we use this framework routinely. For the future, it is very relevant also. So it's relevant as a framework. So In the high TAVR risk group, as we'll discuss, traditionally we size based on the annulus. But do we need to change this in these groups where a valve based on annular sizing may not expand fully? We'll talk about that a little bit. So in the intermediate TAVR risk group, are there concerns? We may get a good immediate outcome, but are there issues with having a relatively constrained frame? Does this affect durability? Can we improve this again with modifying the leaflets? And in the low TAVR risk group, what are the long-term implications of the aortopathy? So we may have a low TAVR risk morphology, but there may be a coexisting aortopathy. So what do we need to do with that? Do we need to be proactive, or are we currently being too conservative? So we'll talk about these quickly. So in the Evolute low risk study, this was a study that was predominantly excluded the high TAVR risk morphologies. They predominantly relied on annular sizing, and they had good immediate outcomes. The only excess was excessive pacemaker, but otherwise mortality was low. Aortic dissection, annular rupture were basically non-existent. So one has to question, what about the high TAVR risk? Can we annular size for those? Can we annular size morphologies such as these with either circumferential calcium or RAFI calcium with leaflet calcium? So we have to often look to China because for a while they've been treating very high risk anatomies with TAVR, and this was an early generation venous A valve, and it just wouldn't expand. This was despite a good predilatation. The valve wouldn't expand in that, and basically had to be removed. So sometimes when we expand a valve, we run into problems with annular sizing, with a constrained frame, with an infold, and what the impacts of durability with this type of result. So a lot of Chinese operators have relied on downsizing systematically. Professor Wong is here. Obviously, he's pioneered the Hangzhou solution, which is predominantly based on the supraannular assessment using a balloon, and routinely downsizing based on the data from this. This is an example of Hangzhou solution. You see a very clear supraannular seal, and you also see on CT that there isn't really annular apposition, but there's no PBL. There's a good seal with the supraannulus, and the frame is not constrained. So is this better in this type of high risk anatomy? So we move to the intermediate risk. Are there durability concerns? So we do get good immediate outcomes. You see this, these cases done at NYU. You see severe valve calcium, but there is no severe RAFI calcium. So technically this is intermediate TAVR risk by the morphology. And we see a good immediate outcome. We see predilatation at Edwards valve, trace paravalvular leak. The mean gradient may be slightly higher than usual, but still very good with a good valve area. But we see a frame which is elliptical, which is unusual for SAPIEN. We hardly ever in tricuspid valves see an elliptical SAPIEN frame. Does this have durability implications? Here is a similar case where the RAFI is severely calcified, and you see a constrained mid-portion of the frame. Danny Tavr is also on the call. He's pioneered this technique, the basilica technique, and he's developing new devices that can modify leaflets. Is this something we should do routinely in this type of intermediate TAVR risk where we have a channel that the leaflet may be cut either with basilica or novel devices, and then you can achieve a circular expansion? Maybe some cases this would be feasible, some cases it may not be necessary, other cases it may be necessary and feasible, and in other cases it may not be feasible. So we move finally to the low TAVR risk group. What are the implications of an untreated aortopathy? We may get a very good immediate result from the TAVR, but are there implications from the expanding potentially aortopathy? Most people would treat this this dimension of aorta only 43 millimeters. This was excluded from the Peak 3 bicuspid registry, but is anatomically quite a good candidate for TAVR. There isn't an excess of leaflet calcification. There isn't excess RAFI calcification, so it is a low TAVR risk, and the aorta is only 43, so most people would consider this acceptable. But what about this case? There's a 71-year-old and a 49-millimeter aorta. And again, there is what seems to be a low TAVR risk. There isn't an excess of leaflet calcium. The raphe is only mildly calcified. But the aorta is 49 millimeters. So most people would, in a low surgical risk patient, would say, well, the patient needs aorta treated with surgery as well as the valve. But I put to you that this paradigm is based on the concomitant repair. What if you can remove from the equation the AS? And then you just have aortopathy. Do you need to treat this aorta that is 49 millimeters? The guidelines are really based on relatively limited retrospective data. You know, we have experts on the call that obviously will debate further. But a lot of the surgery required in the data from this 45 millimeter cutoff were endpoints based on simple replacement of the aorta during reoperative ABR surgery. The incidence of dissection and other catastrophes post-ABR is very low, particularly in patients with bicuspid valve disease with AS. You see here the other guidelines. So if you do not have AS, then a 55 millimeter cutoff is the class 1 indication. But really, even when you have a 50 millimeter aorta, a surveillance is relatively considered acceptable. So perhaps we need to reevaluate TAVR to find. I'll conclude that TAVR risk imaging classification is enormously useful here and now for clinical decision making. It creates a framework also for addressing these unresolved questions. In the high TAVR risk, we can further optimize the technique and approaches. In the intermediate TAVR risk, we can challenge the durability issue. And in the lower TAVR risk, we need to reconsider are the thresholds for aortic repair in the TAVR era. Do we need to change the paradigms? So thank you very much for your attention, and I conclude this talk.
Thank you very much, Hassan. Please stay on and we will have a discussion at the end of these 3 lectures. So our next speaker is going to talk about optimal TAVR procedure for bicuspid aortic valve disease, balloon expandable device, to be presented by Jinming An from Asan Medical Center.
My topic is the balloon expandable device in bicuspid aortic valve disease. Actually, first Implant Tavr was done in bicuspid aortic valve by balloon expandable valve device. However, the subsequent Tavr trial generally excluded the bicuspid aortic valve disease. Even though recently the latest data show that the bicuspid aortic valve Tavr and tricuspid aortic valve, there is no significant difference regarding mortality and stroke rate, even in SAPIEN 3 balloon expandable device and Evolut R self-expandable device. However, there is some different characteristic of SAPIEN 3 and Evolut R balloon expandable and self-expandable device. The SAPIEN 3 has a skirt, so the advantage of preventing the paravalvular leakage. The comparison between the self-expandable balloon expandable device, the first generation and second generation Tavr device, there is no difference in bicuspid aortic valve registry. However, the complication rate is a characteristic of complication is a little bit different. Annulus rupture risk is higher in SAPIEN 3, but the risk of moderate to severe paravalvular leakage is higher in self-expandable device. In addition, due to the Hassan already shows that the importance of calcification. According to the severe aortic valve calcification, balloon expandable device usually associated with a higher risk of aortic root injury. Balloon self-expandable device is associated with high risk of paravalvular leakage. Previous Dr. Yun's study, the quantified not very arbitrarily classified the severity of aortic valve calcification, almost a qualitative analysis, not the exact quantitative analysis. However, roughly, the asymmetric calcification, LAPEC calcification, alveolar calcification can be considered a high risk calcification in bicuspid aortic valve disease. So the aortic valve disease, because of aortic disease, there is a lot of sizing algorithms, but I think Didier's registry data show me the very important insight that based on his registry that compared with the annulus, the supraannulus diameter is, in most cases, the supraannular diameter is larger than annulus diameter. So when we decided a balloon expandable device, annulus-based sizing would be safe and effective in with a very rare case, the only 8%. So I think for Sapien 3 balloon expandable device sizing is very straightforward. Annular sizing, but do not oversizing. Less than 5% oversizing would be good and safe. I think Dr. Grube will explain the supraannular sizing for self-expandable device. Notion balloon valvuloplasty is very important for bicuspid IS because the goal of the balloon valvuloplasty is to facilitate device delivery, the device sizing confirmation, to assess the risk of coronary obstruction. Even though if there is a very small amount of calcification, I don't think balloon valvuloplasty is necessary even in the bicuspid aortic valve disease. So after introduction of Sapien 3 in our heart center, Assam Medical Center, predominantly we implanted Sapien 3 in bicuspid AS. So far, last 5 years, we implanted Sapien 3 in the 89 bicuspid aortic valve disease patient. So I'd like to share our experience. The bicuspid AS and tricuspid AS is incidence of bicuspid AS is a function of age. The older age, the rare bicuspid AS, but the younger age, higher proportion of bicuspid AS. So the less than 65 or less than 7 years old, about the half of patients have the bicuspid AS, but the very old population, bicuspid AS is very rare. The type 1 bicuspid AS is the most frequent type of bicuspid AS in our heart centers. And type of bicuspid AS, flare type and tubular type is 92% composed of tubular or flare type. Taper type is very rare, only 8%. This is a patient characteristic, 89 bicuspid AS patient is younger, accordingly less comorbidity. Most striking difference between bicuspid and tricuspid is aortic valve and dimension size. Area is larger, perimeter is larger, mean diameter is larger, ST junction LVOT larger than tricuspid AS, and left main height, ICA height also higher than tricuspid AS. Another important finding is valve calcification volume. We quantified the valve calcification at 80-50 Hounsfield unit. Bicuspid AS mean calcification volume is 600, median is 600. Tricuspid AS is only 300, 289. So on average, bicuspid AS has a twofold greater calcification volume compared with the tricuspid AS. So as you know, calcification is one of important risk factor for Tavr implantation. So we adjusted our device size according to the calcification volume and status of bicuspid AS. So in the tricuspid AS, mild calcification, we implanted 10 to 15% oversizing device, but the calcification is severe, 0 to 5%. For bicuspid AS, we try to implant the Sapien 3 oversizing is 0 or sometimes less than 5% oversizing. So compared with the tricuspid AS, bicuspid AS, we implanted less oversizing. This is our oversized volume adjusted device under or oversizing. According to the calcification volume, as I mentioned before, our mean calcification volume for tricuspid AS is 300, around 300. The tricuspid AS device oversizing is around 10 to less than 15%. but for bicuspid AS, less than 10%. But the calcification is very severe, less than 1,000. So bicuspid aortic valve, oversizing is almost less than 5%. Tricuspid is less than 10%. So this is another graph, less than 400. So very limited calcification, severity of calcification, oversizing for bicuspid AS is 8% oversizing, but the very severe calcification, just a nominal sizing, or between the 400 to 1,000 calcification volume, the bicuspid sapien 3 oversizing is just 102. So nominal over the patient with more than 400 calcification volume in bicuspid AS, we implanted the nominal size of sapien 3 device according to the annulus area. I'd like to share the several hour experience. The 79 bicuspid AS, type 0 bicuspid AS, annulus area is 589. The calcification amount is 600. So we selected the 29, 10% oversizing, but regarding the bifurcation, bicuspid aortic valve disease and severe calcification, the 3cc underfill from the balloon. So we implanted the sapien 3. Final angiogram looks fine. Now another case, 79 bicuspid AS, annulus area is 500, type 1 bicuspid AS, calcification is 1,300, very severe calcification. So we selected the 26 sapien 3 device and 2cc underpill down to the 96% oversizing, so 4% undersizing. So very small parabolic leakage, no aortic valve complication. This is another case, 83 bicuspid AS, annulus area is 710 square millimeter, very big annulus. So calcification is 800, more than median calcification severity in our registry. So we selected 29, 91%, so 9% undersizing compared to the annulus area. So even though for bicuspid aortic valve with severe calcification, very small parallel leakage. This is a summary of 3 cases. Bicuspid AS with at least moderate to severe calcification, nominal sizing, sometimes undersizing would be very safe and effective based on the annulus sizing. This is a procedural outcome. Pre-valvulus palsy was done in 74% in bicuspid AS. Post-balloon was done in 15%. No annulus root injury. Pacemaker implantation rate is only 4.5, but a little bit higher risk of moderate to severe parabolic leakage compared with the tricuspid AS disease. Even though the death or stroke rate is no difference, the tricuspid AS is a higher death rate. I think this is due to the older age in tricuspid AS compared with the bicuspid AS patient. This is my final slide. I think we need more experience. Case selection is important. P-value is increased compared with the tricuspid aortic valve cohort undergoing Tavr. But in our registry, no aortic root injury, but we have to be careful for aortic root injury when you implant sapien 3 in bicuspid AS. Tavr for bicuspid AS is not associated with the excess risk of mortality and stroke. Sapien 3 implantation on bicuspid aortic valve is not generally different from sapien 3 implantation on tricuspid aortic valve, but don't do oversizing. Less than 5% oversizing would be safe and effective, depending on the severity of calcification. Thank you for your attention.
Thank you very much, Dr. An. Our next lecture is going to be an optimal Tavr procedure for bicuspid aortic valve disease, self-expanding devices, and this will be given by Eberhard Grube.
So thank you very much for having me again, Dr. Park and Alan and Sushil. It's great to be back. Obviously, the topic here is talking about the optimal Tavr procedure for BAV and self-expanding devices. These are my financial disclosures. And I also like to start with a quote of the late Secretary Rumsfeld when he talked about politics, but obviously that applies very nicely to the bicuspid valve. There are known knowns. Those are things we know. We also know there are known unknowns. That is to say, we know there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know. So if we start with the known knowns, BAV is a frequent disease in the general population and in Tavr patients with some geographic differences. Bicuspid aortic stenosis will be encountered with greater frequency as Tavr moves into younger patients. Bicuspid AS is not included in any of the pivotal trials. No randomized data exists. Tavr is approved for bicuspid AS in the US and in Europe, and clinical outcomes are comparable between tricuspid AS and bicuspid AS when using second generation THVs. The known unknowns, which are the high-risk features of bicuspid aortic stenosis that preclude Tavr. The sizing methodology in BAV is still out. We have to define which is best, even for which valve. Which valve might be optimal for this anatomy, and what would be the result of randomized controlled trial if it's ever going to be done. And finally, the unknown unknowns. How many patients will continue to need surgery if a randomized trial of Tavr versus Tavr will ever get done? So let us come down now with procedural considerations for the self-expanding valves, the known knowns. The CT scroll technique in BAV is important. Examination of the images can identify the following location and morphology of cusps and leaflets, presence of any raphe between the leaflets, extent and distribution of calcium, location of coronary arteries, size and shape of supraannular EOAs. Critical additional CT measurements are shown here: the iliofemoral anatomy, measurements of the ascending aorta, sinus of Valsalva and annulus, and of course, the coronary height. Procedural consideration, which I'll discuss briefly, in bicuspid should follow standard implantation best practices with minor adaptations to address the unique characteristics of the bicuspids, for example, the projections, pigtail wire position, pre-dilatation, pacing, frame expansion, and post-dilatation. So pigtail and wire consideration. Place the pigtail at the bottom of the non-coronary cusp with the catheter following the greater curvature of the aorta. Bicuspid anatomy may actually alter the wire position, often displacing the wire posteriorly and resulting in increased device parallax. Consider pre-dilatation and a stiff wire to help achieve a more favorable and stable wire position. Balloon pre-dilatation, very important in BAV. However, you have to pay attention because a caution must be taken to prevent annulus rupture, as has been said before. Following the recommendation that the balloon should be short, straight, and sized according to the chart below, the minor axis and the non-compliant balloons -1 millimeter. Don't be too aggressive in pre-dilatations. Coronary temporary pacing. You should consider pacing to increase valve stability. Begin pacing with the marker band as the third knot. Rapidly deploy from the annular contact to before the point of no recapture, as unexpanded by a prosthesis temporarily obstructs the cardiac output. Discontinue pacing before reaching the point of no return. However, consider stepping the pacing rate down incrementally. Just don't stop pacing immediately because it might dislodge the valve. Confirm frame expansion in 2 views. Very, very important. In addition to assess PVL and hemodynamics, change the rotation from LAO to RAO axis, or obtain a short axis echo view of the inflow to confirm frame expansion. If unfolding or under expansion is noticed before TAP release, consider remove the system and perform a pre-dilatation before attempting a second valve. Balloon sizing for post-implantation dilatation or PID, 2 primary factors have to be taken into consideration. 1, the PID balloon must be sized smaller than the annulus perimeter-derived diameter to mitigate trauma to the annulus. And second, PID balloon size must be less in order to avoid the expansion of the waist to damage the valve leaflets. If for any reason you have to do intraventricular bailout balloon dilatation, which is to say a balloon placed in the ventricle in order to go down and not avoid the waist, then do it with smaller, pay attention to smaller ventricular cavities, presence of left ventricular outflow calcification or wire positioning, because the wire might actually interfere with mitral valve functions. Obviously, complication with BAV have to be considered and very important. Paravalvular regurgitation, as Jean-Min has pointed out, and very important, contained sinus rupture as shown in the lower part, which is obviously the most devastating complication that you can achieve. Also, SOV thrombus resolved with warfarin are shown here if the valve is not deployed properly and it's underdeployed. Very important, and actually better known than in the early days, is valve infolding. And you can see here with the yellow arrow, watch it before you implant the valve. And I would like to share with you a case of the early days, a calcified annulus 24 millimeters, and you can see here heavy calcification of the annulus. A 29 millimeter valve was deployed without pre-dilatation in the usual fashion. The valve seemed to be well positioned, but what you can see today, better than in those early days, a closer look revealed a fold in the valve. The valve was clearly underexpanded, resulting in a significant posterior leak and remaining grading of 45 millimeter mercury. At that time, we didn't quite know what to do, so post-dilatation was attempted with a 25 and 28 millimeter balloon, but not much change. As you can see here, the fold is still there. The gradient decreased, but the regurgitation increased. Not good. A closer look at the CT, it showed an infolded valve, very nicely seen together with, if you look at the middle age, an underexpanded valve constrained by heavy calcifications around it. The immediate explant confirmed a V-shaped valve. A few minutes later, the valve was back to normal, so it was not a valve problem, it was a constrained valve by the calcifications. Surgery confirmed BAV with massive calcifications, as shown on this slide. Lessons learned, mistakes have been made. Careful evaluation of echo, BAV was not diagnosed then. Evaluation of calcium, amount and distribution. Careful sizing considerations, careful was massively way oversized. Careful inspection of the implanted valve. In the early days, infolding was known, but rarely seen. Watch out for the fold. Aggressive post-dilatation should only be performed when reasons for gradient and leaks have been identified. Not all folds can be unfolded by ballooning, as seen in the previous case. If, after post-dilatation, the problem persists, consider surgery or implant of a smaller valve that pushes the fold to the side. Sizing for bicuspid AV, and Hassan has pointed out of them, various sizing methodologies have been proposed for Tavr and BAV: annular sizing, supraannular sizing, and balloon sizing. Additional considerations should be given to the following when determining appropriate Tavr sizing: degree of calcification. Will calcium density and location impede TAV frame expansion, as you see in the previous case? Location and length of the raphe. How many leaflets are fused, and does the raphe extend the full length of the commissure? And obviously the SOV width and the height. Also, if we look at the implant view, which might change a little bit from tricuspid valves, but basically the bicuspid implant view preserves key principles of the standard cusp overlap view for accurate depth assessment deployment. Don't be afraid to place the valve higher than usual, because the leaflets are the ones that anchor the valve. The Harvard study found that annular-based sizing was applicable to 88% of the patients. So that's probably the one that's being used most. And finally, you have seen the slide before, balloon aortic valvuloplasty more often used than bicuspid AS. The reasons why are shown here, and Jangmin already pointed this out. And never forget, post-implant views in LAO and RAO. As shown on the left side, everything seems to be okay. On the right side, you can see what's happening. And unfortunately here, you can see the valve, the wire has been removed. Very difficult to re-enter the ventricle. So take-home message, Tavr technique for bicuspid valves. CT sizing is gold standard, but still empiric. Pre-dilate, use minor diameter of the annulus as a reference. Consider controlled pacing during deployment. High implants, anchoring in BAV is not the annulus, but the leaflets. Assess stent frame expansion in 2 orthogonal views. Post-dilate, if necessary, minor annular diameter, mean derived diameter, again, as a reference. And importantly, consider use of cerebral protection devices in BAV. Thank you very much for your kind attention.
Thank you very much, all speakers. So we have about 10 minutes for discussion. So anyone has a question can raise your hand or just speak up. Maybe I'll start up just asking a question about implant techniques. So if you have a pretty heavy calcification and the raphe is calcified, maybe the full length of it, do you actually modify any of your sizing, your technique? Because the concern is not just the calcification, just obviously restricting the expansion, but potentially pushing that raphe out of the annulus, sort of a spear-like effect. Any modification, or you just sort of do it carefully, as we usually say? Anyone want to tackle that?
Yes, for the balloon extendable valve or aortic injury, should be careful. But first of all, I think overall amount of calcification is very important. So before procedure, we quantified the aortic valve calcification by CT. So the CT showed that the very severe calcification. Then we underfill the balloon, the inside of the device. So we do not oversizing too much for severe calcification with the calcified raphe. So around 100% nominal sizing, or sometimes less than nominal sizing, initially implanted, and then look at the aortogram. The aortogram show that sufficient room for further dilatation, and there is just some significant paravalvular leakage. We do the one more post dilatation. This is our strategy. Even though in our registry, only 14% of patients received the additional post dilatation.
Perhaps I could ask Danny a question. Hassan sort of talked about your tricuspidization technique that you've sort of pioneered, and there's no ideal valve. I mean, what is your belief? Do you think any one valve is better for bicuspids, or do you think that we need to modify leaflets? And do you have any experience you can share with this tricuspidization that you've done on patients, and how applicable it would be across the spectrum of bicuspid valves?
Well, I think that obviously we have very limited data. It's around 10 cases that I've performed. And basically the calcified rougher ones were the most appealing ones for doing that. Because when you do the slice, the basilica slice, just adjacent to the rougher, the calcified rougher, my feeling from the cases was that it allowed more expansion towards that side of the calcified rougher. Because the issue of having like a non-deflectable structure close to the center of the aortic valve annulus is creating a big issue for deflection of leaflets. Usually when we do Tavrs, we learned that there is no issue with deflection of leaflets. We put a valve, if we inflate a balloon, it will go aside. If we do something with nitinol strong radial force, it will go aside. But what do we do with that calcified rougher near the center? That's a problem, I think. So I think maybe we need to focus. And my God, these cases were amazing. Eberhard, I was shocked by the non-deflection of the leaflets in several of these cases. Some of them, in retrospect, could have been advantageous to cut something just before.
I think Vinny would say the advantage would have been to cut the skin in the sternum in those cases potentially. But
so I have a quick question to Hassan. Is a couple of problems when I have seen, especially with balloon expandable valves, is when one leaflet is heavily calcified in type 0 and the other one is not at all calcified. And unfortunately, in your CT classification, that morphology has not been shown. We had a case just 2 weeks ago here, which was very similar. And what happens is the valve expands in one direction, and that led to a big aortic injury and tear into the right atrium. So that's something I always feel one should assess as well.
I think you're absolutely right. I think the other thing I've seen is migration sometimes in that setting where there's such extreme asymmetry. And I think one of the humbling aspects is there's so much variation that no doubt you see every day in bicuspids that is just you have to start somewhere with the framework. We've found this very useful to separate out the big entities, the big subsets, and we're using that routinely in describing. But there are outliers. I added that circumferential calcium that I'm starting to see cases of that even in New York, but I first saw that in China where you have a type 0 where you have this circumferential calcium, and I hadn't seen that before, but it's relatively rare. So we no doubt experience these things. So I think it's important the community reports such experiences so we learn from it.
Eberhard, you had a comment before. I don't see Eberhard.
Oh, that's okay. I was talking about Danny's, the question that Sushil raised, and I'm wondering, because what Jiangmin said is that in balloon expandable valves, the valve remodels the annulus, which obviously is more impacting the anatomy of the annulus with consecutive potential problems like rupture. Whereas a softer, or maybe you call it less aggressive approach, or softer approach, where the opposite is being achieved, that the annulus remodels the valve. I think the lessons that I've learned, and I'm with Hassan on that. When I was in China and spent some time in Hangzhou with Jiangmin, the most important lesson I learned was when he did the balloon sizing. If you recall the early days there, he step down the balloons until he found the best. Basically, it was always undersizing, and never be too aggressive in positioning. Low, you can even position it higher, and the undersizing. I think that was the key message. You know, I'm still admiring the work from Asa Medical Center when they do their measurements and their charts on what and how to do when you have a given amount of calcium. I think in bicuspid valves, you know, I would much rather approach it a little bit more individually, not going by charts so much, but much rather say, this amount of calcium is there, the chunk of calcium is there. Maybe it's better to use a self-expanding valve versus a balloon expandable valve than using a chart. But that's just my obviously personal feeling about approaching the bicuspid anatomies.
Right. Yeah, Aberhard, I agree. Is that I think the amount of calcification give you a general guidance about what the problems are, but the individual distribution, I think you have a very light calcification, but in a crucial spot, you can still, you know, split it with the slightly oversizing. So I think sort of a general guidance of valve calcification amount is good, but then, you know, each one can still be hazardous if you don't look carefully about where the calcification is.
Yes.
Thank you. So I think we're going to move on to the next segment. Sushil, you want to take over to introduce the lecturers?
Wonderful, thanks. And we have three more wonderful lectures, this time focusing on sort of complex TAVR scenarios. And our first speaker will be Dr. Van Meegen from Erasmus University, talking about coronary disease diagnosis and management pre and post TAVR. Nicholas?
So thank you very much, Sushil, everybody. Thank you for having me in this session. And I'm going to discuss coronary disease diagnosis and management before and after a TAVR procedure. These are my conflicts. And just to set the stage, coronary artery disease is quite common in TAVI, and when we treat TAVI, it will be present in more than 50% of the patients. In this summary of studies, you see that it varies up to 80%, but it can drop as low as 20%, and that obviously has to do with in- and exclusion criteria of contemporary and past randomized controlled trials that excluded patients with advanced coronary artery disease. So a lot of the information that we have is derived from registry data and post hoc analyses, but not of prospective randomized controlled trial data. There has been a lot of research going on in terms of using coronary CT for coronary artery assessment prior to TAVI. And the results are quite promising, but the number of these trials are quite low. But still, sensitivity and specificity to identify significant coronary artery disease is quite high in these selected set of data. But I have to say that still in patients with very calcified coronary artery disease, the yield and the positive predictive value of coronary CT may be not as good as we would want it to have, but I think the field is moving in the right direction. So still we need to rely on coronary physiology or invasive coronary angiography, and oftentimes we will use coronary physiology. And this is data from the group in Bonn, where they looked at FFR before and after TAVI. This is a small study of only 13 patients. And what they realized was that basically it didn't mean, there was not a lot of difference between the FFR before and after TAVI, at least in their experience. And this is a little bit strange because when you have severe aortic stenosis, oftentimes you have an increased left ventricular end diastolic pressure, and that will result in increased microcirculation compression. You will have more backward flow, you have less vasodilator capacity, you have less of an hyperemic effect, so less flow, and you have less forward flow. So basically you would anticipate that that might affect your coronary physiology, especially your hyperemic indices. And this is an example from my center where we are in the midst of the POTUS trial. The POTUS trial is a prospective study where we do a whole series of coronary physiology testing before and immediately after a valve implantation. And also we did that in this case, and you see some luminal irregularities in the proximal LAD, extending into the mid segment. And we did an FFR. The FFR was 0.83, but at the end of the procedure, after the valve was implanted, the FFR dropped to 0.74. And look at the table where we compare all kinds of pressures, but also coronary physiology indices before the TAVI and after TAVI. And as expected, our LVDP dropped almost halved after the procedure. Our mean gradient dropped from 55 to 11, and our non-hyperemic diastolic index remained the same, was stable, but was at a level where you would anticipate a positive FFR in the absence of aortic stenosis. And sure enough, the FFR was 0.83 before the TAVI, but after TAVI, as I mentioned, it was 0.74. So we proceeded with treating this this lesion, but I think this case illustrates what also was demonstrated by Matthias Gottberg and his group, where they did a series of only 28 patients, but also found in that series that after a valve implantation, the LVDP dropped, but also the flow changed when you look at FFR flow. If you look at PDPA flow during diastole, no significant difference in flow, but if you look at the FFR flow, there was a clear increase of flow, more hyperemia after the valve implantation, and that translated into basically no difference in IFR, which is of course a non-hyperemic index of coronary physiology before and after TAVI, but there was a clear drop in FFR before and after TAVI, making some of their lesions becoming significant and requiring revascularization after the TAVI procedure. So I think this is very interesting new insights of coronary physiology. Now, then the question is, okay, like you have a significant coronary stenosis. When do you need to treat this? Do you need to treat this before or after the TAVI? Well, that is always balancing. You know, there is a benefit of treating it before, because if it would be clinically or hemodynamically that significant, obviously when the patient still has aortic stenosis and you're treating the coronary lesion, yeah, the patient, that might jeopardize the hemodynamics of the patient, but also vice versa. If you would leave that lesion and first proceed with a TAVI, that also might affect hemodynamic performance of the valve as you are implanting the valve. So basically, I think the word is still out. What would be the best strategy? Do you need to do the intervention, the coronary intervention before the valve, or vice versa? Maybe it is not a one size fits all. Maybe in some patients, the valve implant needs to be first, and in other patients, the coronary disease needs to be treated first. And I think there are multiple trials ongoing that are looking into that controversial issue. For instance, the TAVI PCI that is currently unfolding in the German-speaking countries, but also in the Netherlands. But then the question is, okay, if you have significant coronary artery disease, do you need to treat it, especially in the elderly patient population that we are predominantly targeting with a Tavr procedure? Well, this is data from my own center where we looked at the impact of complete versus incomplete revascularization. And what was quite obvious, that in the majority of the patients, we only had modest reductions in the syntax score. So basically, we were only targeting the most significant lesions. If we then compared outcome of patients who obtained complete revascularization versus those patients who did not, and we're still talking about more than the 250 patients, well, basically there was no difference in patients who had incomplete revascularization as compared to complete revascularization. And also, if we looked at the residual syntax score, there was no difference in survival in patients with a residual syntax score more than below or versus below a syntax score of 8. So that data basically was duplicated in a randomized control trial, a relatively small randomized control trial performed in the United Kingdom. 235 patients from 17 centers were randomized 1-to-1 to PCI or no PCI. But again, the mean age of the patients was 83 years old, an STS score of 4.4, so at least an intermediate elderly patient population at intermediate risk. And what they saw was there was no impact, clinical impact of performing the PCI, but performing PCI came with an increase in bleeding, obviously, because the antithrombotic regime was more aggressive in those patients. So let's switch to coronary access after the TAVI. Well, there are patient-related and TAVI or Tavr related factors that determine the coronary access. And so in terms of the patient-related factors, is the coronary height, it's the length and the calcification of the native leaflets, and it's the dimension of the aortic root that includes the sinotubular junction, the sinuses, and the ascending aorta. And then there's also the factors related to the transcatheter aortic valve procedure, whether you are embarking in a valve-in-valve, whether you did or you did not do commissural alignment, your valve selection, the implantation height of the device, and the relative proportion of the valve relative to the sinuses. And this is an important issue, the spatial relationship between the valve frame, the sinuses, and the coronary ostia, as is visualized here, and also the length and the bulkiness of the native, or if we do a valve-in-valve, the bioprosthetic leaflets. And you can imagine from this cartoon how it becomes more difficult if you would have a high implant and a low coronary height, that might affect your coronary accessibility. And you need to be aware of the specifics of the valve that you are implanting. Is there a sealing fabric or not? How high is the fabric? How high are the leaflets? And it's different from the different valve platforms that we are using. And also the framework has a role to play. So again, to make it more visual, this is how these devices are seating in coronary anatomies, and you can immediately appreciate how coronary access might be different from different devices. And this illustrates and compares Evolut with a sapien valve. And look at the circle. The circle is basically the coronary ostium. If you have a sapien valve, then oftentimes it's not difficult to re-engage the coronaries. Only when you have a very high implant in a patient with a low coronary anatomy, then the sealing fabric and the inner skirt might interfere with accessing the coronary access. It's a different story with an Evolut valve that obviously has a higher frame, that these days also has a sealing wrap, but also the leaflets are implanted much higher. And you see that the interaction with the coronary ostia will occur much more often. And this is also elegantly demonstrated in this study from the group in Milano, where 2/3 of the patients who had a core valve versus only 4% of the patients who had a balloon expandable valve had issues with coronary access. And that raised or triggered an interesting editorial by our good friend Gilbert Tang, where he demonstrated that, you know, the coronary height, the transcatheter frame height, the leaflet height, commissural alignment, and the valve to coronary ostium distance is very important. Again, here, if you have a valve that remains below the coronary ostia, there is no issue whatsoever. When you start to interact with the ostia, there it becomes important to do commissural alignment, but also to take into account the distance between the valve and the wall. In the re-access study of Marco Barbanti and the Catania group, they also identified these small sinuses, a high implant of predominantly an Evolut valve, as predictors of not being able to access the coronaries. And they elegantly demonstrated that before the TAVI, it was 100% sure that you were able to access the coronaries, but after the TAVI, it became more difficult, especially for the right coronary, to be re-accessed in up to 1/3 of the patients. And that translated into more time that was required to re-access, but also more contrast, both for the left coronary and for the right coronary. So again, this has been duplicated. So we know that the aortic root dimensions and the valve play a role. And to wrap up, the PCI strategy post-TAVI, in principle, when you can access the coronary ostia selectively, then it's very easy to do your PCI. If you're not able to do that, then you may need to change your guiding catheter, or you may need to change the frame cell that you perforated or that you navigate it through. But if that is not successful, then you need to embark in a fishing technique with a hydrophilic wire and use a guiding extension catheter. Oftentimes you will be successful. So in conclusion, coronary artery disease and aortic stenosis often coincide. The need for coronary revascularization is unsettled and may depend on patient characteristics, age, and comorbidities. You need to understand as an operator the spatial relationships between the transcatheter heart valve and the aortic root anatomy. The value of coronary physiology before and after TAVI is unclear, but there are some prospective trials on the way to further stipulate what is required. But it's essential, coronary artery disease is essential in lifetime management after TAVI. I give the word back to you, Sushil. Thank you for your attention.
Thank you, Nicholas. That was a wonderful presentation, and we'll have a discussion here at the end of all three talks. Our next speaker is Dr. Bapat from Abbott Northwestern, talking about optimal management of Tavr failure. Vinny?
So I think I'm going to take off because of time as well. And so the most important thing I want to highlight here before we discuss Tavr management of failures is we use tissue valves for two reasons. One, to avoid anticoagulation, and one, to avoid reoperations. Most of the time, we tend to use them in elderly patients. But at the same time, we know now that all the tissue valves will fail. And with the current predictions, similar to probably a lot of surgical valves, if we use them in low-risk patients especially, the prediction will be maybe up to 10 years, they will last maybe up to 12. So if we implant them in patients with longer life expectancy, then I think structural valve deterioration won't be uncommon. So what would be the second intervention to manage it? And obviously, as a surgeon, I always felt that the most important intervention could be just to explant the TAVRs. But at the same time, we have to remember that a lot of TAVRs are done in high-risk patients, intermediate-risk patients, and intermediate-risk patients also who have had some reoperation before. And so there is a appeal in doing a TAVR in TAVR, so which could be better. And at least at present, as I think taking from Dr. Grube's slide, is there are known knowns and there are many unknown unknowns here. This could be just a promise and this could be a reality. So let's look at a couple of things. Is the current registry data of TAVR in TAVR, very few cases, I would say up to around 200, 250. A lot of these patients have been, implanted. They're elderly patients, not probably suitable for any other intervention. There is certain risk of pacemaker. There's a risk of high gradients. And again, I think the main concern about that is would all these patients land up with anticoagulation? So I think the reason I say that is when we are going to put a TAVR in TAVR, let's not forget that there is more metal in that constrained space. And again, I think extrapolating from some of the diagrams by Nicholas, there's going to be a lot of metal in a very small space with sequestration and abnormal blood flow. We are going to also have some issue with under expansion of the new TAVR, unless, of course, we use a taller TAVR device in a shorter TAVR and so on and so forth. The other worry is we have many TAVR designs, so we still need to understand how they would interact with each other. What I mean by that is how they will not just interact with anatomy, but how they will interact within each other. And by that, I mean is we need to understand which combination is going to give us the best gradients or least gradients in the end. Let's take just an example of one of our patients. She's a 75-year-old patient who has had, planned TAVR. This was the annulus and a SAPIEN 3 was implanted uneventfully. And then, in early 2019, when I was in Colombia, you could see that there was, a bit of a problem with this TAVR. Patient became symptomatic, and then we decided, we have to do intervention. Now, this patient by now is, much elderly. She had multiple comorbidities, so which could be an option. When we do TAVR in TAVR assessment, we really have to understand a lot of other things. One is a phenomenon called neoskirt height. And again, this is very important, especially in sinotubular junctions, which are narrow, and especially with the fact that we are implanting TAVR devices higher and higher. Second important thing is what size of TAVR device we're going to use. And the reason I say that is, for example, this is the 23 SAPIEN 3. but we have used it in an annulus which is from 18.5 to 22. And this may be either 18 millimeter expansion or it could be 22 millimeter expansion. And I think this is really important to understand what best TAVR size we're going to use. Also, are we going to, like fracturing, are we going to actually try and expand this TAVR bigger? So going back and analyzing the native CT for annular damage risk is again critical in these patients. There's another phenomenon called leaflet overhang. Now, we don't normally see that in the native valves. Probably some of us might remember them when we use Sapien and Sapien XT when we're implanting 50-50. But if we do a higher implant, the leaflet overhang doesn't appear. But at the same time, there could be a risk of coronary obstruction. But if you do a low implant of a shorter device in a taller device, you can get a leaflet overhang at the top, and that may interfere with the function, not just the opening, but even closing of the new TAVR device. So if you are using a combination like this, you will probably never get a leaflet overhang. And I think you will all agree this is a much shorter device. But if this is a taller device, you can see it in this video that you will 100% get a leaflet overhang. Now, mind you, this video is in a normal valve, but just imagine that the top valve is actually stenosed, and then that means is you're going to leave behind significant stenosis. So again, we need to understand ideal positioning and also calculate for coronary obstruction risk or any other complication in these combinations. Again, the next thing is surgery. Is surgery easy in this patient? So I divide surgery generally into two, shorter profile devices and taller profile devices, because explant techniques are slightly different. When we are doing explant in a shorter profile, especially balloon expandable by design really engages with the LVOT, and explanting it can lead to some damage to the annulus and mitral leaflets. And this LVOT flare, you have to take care really cautiously, as there is a lot of pseudoendothelium growth at that time. This is just an example of how we can explant sapien valves. There are a couple of techniques. In this particular technique, what we do is essentially cut the sapien valve right in the middle and then slowly pinch it on the side and then take it out. Again, initially our impression was removing shorter devices is going to be very simple, but trust me, this can be really tricky. As you can see here, compressing that valve in the center takes a lot of effort and a lot of patience. And if you rush this by any chance, it leads to complications such as mitral leaflet tear or conduction tissue damage. So here, what the operator is now finally doing is taking a wire cutter actually to cut the stent frame, and that will allow him to compress this valve and bring it out. There are many other things as well. I call this a crocodile roll. Essentially, what we do is, identify the sapien valve, take the same bone cutter right in the middle. I'm just going to forward it a bit, and then hold it with a needle holder and simply roll the needle holder on it itself. And you will see that with this technique, apologies for the hair bobbing a bit while taking this video, the operator can simply unroll this device. And we need to also be careful at that time that you're cutting the native leaflet at the same go and make sure that the annulus is not damaged. If it's a freshly implanted valve, for whatever reason you need to take, this is a pyramid technique, just bend it inwards and it just comes out. Some of us might remember a valve called direct flow. I'm just going to forward this again a bit, but this was a valve where we infiltrated polymer at the end of it into the two rings, one below the LVOT and one above the LVOT. So you can see that if these patients come back, it is extremely difficult, especially in smaller valves, because their internal diameter is very tiny. And this is how it looks like during surgery. It is completely incorporated in the native anatomy. These valves have to be removed piecemeal. If you are not careful, you're going to damage a lot of things, including coronary arteries. And you can just see here that how this valve has been removed piecemeal. What about taller profile devices? All the taller profile devices are made of nitinol. And here, again, A careful dissection avoids complications such as aortic damage and aortic root damage. This is one of our cases from Colombia again. With respect to time, I'm just going to forward this a bit, but essentially what we do is we identify the coronary location, we look at the LVOT and make sure we understand how low the valve is and what the relationship is with the mitral annulus especially. And then we carefully dissect the pseudoendothelium and the stent from the aortic wall. And you're going to see that slowly. One of my residents is actually doing this case. And as you progress, the best part about removing nitinol, to be honest, is it's very compressible. So as you progress, as you can see here, you can lift it very nicely. And once you lift it from the aorta, you can then slowly lift it from the subannular part. And then once you do that, you can explant the valve very easily. Again, we showed a live case at the TCT as well, which was a bit more complicated than this. And we snared it inside a 18 French cook sheet by attaching some prolines to this device. Very quickly, we have a surgery after Tavr registry. And some of the key findings of this is that the mortality is still high. Initial results were very poor, but I think even with improved techniques, all these patients, when they get operated, you can see that is going to be a problem in future. Some of these patients or most of these patients are still getting operated for endocarditis, but at least 23.6% for structural deterioration. And you can see that overall survival at around 36 months is 73.3%. So to conclude, Tavr failure is going to be common. I think an important heart team discussion of risk of either of this is very critical. And if you want to do Tavr, then you need to understand the risk of coronary obstruction, Russian doll effect, and leaflet overhang, and probably also annular injury. And if you are attempting a Tavr explant, you need to understand how complex the procedure is going to be. Thank you.
Thank you very much, Vinny. We're going to move on to the final speaker of this session, which will be Dr. Park from Hassan Medical Center, talking about the clinical impact of patient prosthesis mismatch after Tavr. Dr. Park?
Okay, thank you, Cecile. So today my topic is about the debatable issue about the prosthesis patient mismatch after Tavr procedure. This is my disclosure. As everybody knows, the Tavr, the PPM issue was a very long history, nearly 30 years ago, and this is the first issue in the SAVA field. And on the side is the SAVA valve in the large aortic root. This is an effective prosthetic valve area. It's a much smaller normal human valve. So, and the definition of the PPM that we are now apply the FACA2 and FACA3 definition, and that there are some little change of the value of severe PPM. FACA2 applied 0.60, FACA3 is 0.55, and prosthesis with normal function but too small for patient body surfaces area. Also, there are methods to define PPM and measured or predicted index the effective orifice area, and we know where the measured is much smaller than predicted EOA on the basis of the measured versus predicted, and the overall instance of a PPM some different. So, and if you think about the theoretical concern of a PPM in clinical practice, so theoretically, small aortic annulus associated with higher leaflet mechanical stress. Leaflet mechanical stress could be main determinant of the structural valve degeneration. Also, small aortic annulus is associated high risk of the severe PPM. Severe PPM could be associated with the increased risk of SVD in SAVR. This is a theoretical concern. The look back, the current available data, still controversial data. Some data show the PPM was associated higher instance of mortality and adverse cardiac event, but some data shows there is no difference at all, the presence or absence of the PPM. Long-term data on prognostic impact of PPM on structural valve degeneration is still lacking. This is one of the representative data. This is ACC TVT registry, and the Herman data are looking at the known predictor of PPM is valve-in-valve and the small size valve less than 23. And the central illustration showing the mortality impact, there is no difference, no PPM, and the red line is moderate PPM. However, in patients with severe PPM was a higher instance of the mortality, but this paper also largely criticized a lot of unmeasured confounder. Some data from the Ocean Tavr registry and Kentaro Hayashida is read, and this big size registry in Japanese code. And according to presence or absence of PPM or severity of the PPM, there is absolutely no statistical difference, all-cause mortality and cardiovascular mortality. There is no clinical impact of a PPM. So non-predictor of the PPM, and there are many factors was known: diabetics, renal, large body surface area, and the Tavr, and the valve-in-valve, and the well-known is a small aortic annulus and the small prosthetic valve size. This is more common in Asian rather than Western population. This is a well done, nice review articles I did with Kentaro Hayashida and the Tavr replacement in Asia in the present status and future perspective, and the JAG Asia review article, and the Jian Wang is editor-in-chief, the JAG Asia. And this is a representative data figure showing the compared to the Western Asian population is the low BMI and the low size of annulus area and device size and the higher instance of a bicuspid valve, and theoretically PPM may be particularly relevant in Asian population with a unique anatomical feature. But then we compare the direct comparison on the basis of the recent TCTAP registry and the racial difference of the incidence and clinical impact of the PPM. And this data in the 3 centers was combined, and Assam Medical Center in Korea, Stanford in United States, and Northwestern in United States. And we clarified 562 Asian patients, 539 non-Asian patients published in the JAG intervention recently. And looking at the baseline characteristics as expected, BMI was much lower and compared to the Western non-Asian, mostly Western population. Body surface area is much lower, 1.58 Asian, and the non-Asian is 1.91. That was expected. Also, and the bicuspid valve is much common, and the mean pressure gradient is much higher in the Asian population. CT finding shows the perimeter and annulus area is much smaller than Western population. So, and the overall procedural characteristics in the Asian population, much smaller size of the valve was implanted as expected. And this is a very interesting data in the echo-hemodynamics. In Asian population, effective orifice area 1.5 and the non-Asian 1.52. The indexed EOA, however, is much larger. It's 0.94 in Asian, and the non-Asian Western was 0.80. And looking at the peak velocity, pressure gradient is much higher in Asian population. If you divided the BSA, body surface area, indexed value, much better in Asian patients. There was, the racial discrepancy of the PPM. So, and overall PPM instance on the basis of FACT2 criteria, and the non-66% in Asian, 55% in non-Asian, moderate towards 26%, 29%, and importantly, severe form PPM was present in 7.1% in Asian, non-Asian Western population, 25%. So, and the main determinant of the PPM is body surface area is the most important factor to determining presence of absence of the PPM. So, and there was a impact about the primary composite outcome, defined the death, stroke, rehospitalization, and each individual component, there was no difference, presence, or absence of a ppm stratified Asian versus non-Asian. There was a central illustration. Although BMI, BSI was lower in Asian population, overall instance of the ppm much less frequent in Asian patient, and the severe form is much common in non-Asian patient. However, interracial disparity in ppm impact was absent. So this is a key message of the TB-TAP registry. So ppm in the TAVR area, is it becoming obsolete? And in the early period, the server, there was really matter. And nowadays, severe ppm is rare with minimal impact on outcome. So this is my last slide. ppm, still unknown issue. Definition of the ppm, still arbitrary and controversial. So accurate definition is required to correctly classify patients with real hemodynamic obstruction and properly assess the implication of the ppm. ppm, we don't know, is it pathologic finding versus just the physiologic phenomenon. Also, ppm is frequently talking about that this is the ratio fallacy, mainly driven body surface area. Is it the modifiable factor or non-modifiable factor? And the ppm could be key determinant of valve selection. If you think about the ppm is key determinant, we should more preferentially select the self-expandable with a large effective orifice area. And most importantly, it is still uncertain and whether ppm may impair TAVR durability and how this phenomenon is applied in decision-making of a valve choice and the risk stratification. Thank you for your attention.
Thank you very much. That was a wonderful overview. So we have about, I think, 10 minutes for discussion here. Maybe we'll just go in the order of the presentations. And David, maybe we'll get a comment from you about coronary disease. And I know you're running the complete TAVR study, and there you're focusing on revascularization post-successful TAVR. Is there a patient where you feel that has to be revascularized before, or do you think these decisions are all, we're overthinking the importance of coronary disease and we need to really sort of refocus how we approach it?
Oh, Sushil, my friend. Look at this group. So it's a holiday in Canada. It's the middle of the night, and only this group could keep me this engaged right now. If you'll let me, I'll make two comments. First, Nicholas, fabulous presentation. What I would say is, if you have a patient with severe symptomatic AS and concomitant coronary disease, please put them in a study in 2022. We have complete TAVR, 106 sites, 4,000 patients enrolling over 4 years. We hope with the other studies enrolling in Europe and around the world that we'll be able to change the guidelines similar to what we did with STEMI. There is no patient, to be honest. Obviously, if you have complex severe distal left main in the heart team, that patient's going to go for surgical AVR and CABG. But if you have a 70-80% proximal LAD dominant circ right, those patients are being randomized, and I think they're being safely randomized, and I think we have a steering committee to back that up. But if you'll permit me, I would love to talk about the great presentation by Vinny and then Dr. Park, my good friend. Oh my goodness, this is the hottest topic out there, right? If we do any type of modeling for 2032, you're talking about 30 to 50,000 THV and THV. So what I would say is, all of us around the world, it is our responsibility for any patient with longevity to model it on CT and sort out what you're going to do with the second THV. And because of the hemodynamic and the PPM piece, we have added a lot of cost to complete TAVR by adding in a core lab for both invasive hemodynamics and echo, so that hopefully we'll have those results in 2026 as well. But to me, that is the huge topic. And I love Vinny's pictures, and I know Eberhard's not on anymore, but Danny, I agree, those pictures Eberhard showed, those were like a horror movie. So I'm glad that we're beyond that now. Thank you.
Dr. Wong, you had a comment? You had?
Okay, I just ask, it is an open question. So For the evaluation of coronary anatomy, do you believe in the CTA scan or you routinely do the coronary angiogram? As we know, usually, regularly in our center, we just giving patient one injection of contrast to achieve two purposes. One is for the whole anatomy of the aorta for the Tavr procedure. Same time, we get information for the coronary anatomy. Do you think this information is enough? It's big enough, or for some patient we need routinely do the coronary angiogram? So, what is the open question?
So Sushil, if I can make one comment, I think many of us are using CT as screening, and we're doing that in our regular cases. And if it's minimal or no epicardial disease, even with severe AS and all the calcification, we're happy. But I think it's ambiguous enough that we're mandating both the CT and the invasive angiogram and complete Tavr, and I know other studies are doing that as well, so that we can truly understand this and kind of put it to rest. But Nicholas, sorry, you were going to say something.
Well, yeah, I think you want to avoid the unpleasant surprises, right? Because there is also the issue that you invested your time at that point of the day to treat the valve, and all of a sudden you get exposed to a proximal LAD or a left main disease, which is not uncommon in these patients. So I would still encourage to have a complete coronary assessment prior to entering a Tavr procedure. And oftentimes you can get away with a CT scan, but I have to admit that is not our practice at this point in time. We're still doing invasive coronary angiograms in almost all our patients. Alan, what are your... Oh, sorry.
No,
Go, sorry.
No, I was just going to add, for me, it depends on the patient risk profile as well. If someone's 80 and I'm going to do a Tavr, it's not going to, and the coronary disease isn't going to swing me one way or the other. I feel comfortable if the CT scan is good enough to clear the proximal disease that would make us go to surgery. I feel comfortable saying, okay, that's okay. And at the time of the Tavr, I take a couple pictures, and David has told me that that disease needs to be randomized anyway, so I can't treat that up front. So I'll diagnose that single vessel disease at the time if needed. So, but if the patient is 68 and this is going to impact the decision making, I have a lower threshold to get the coronaries before. So I think it's hard. And you know, doing the cath before, you know, exposes two procedures, another risk. It just depends on the risk profile. But I don't know if others think differently.
But don't you think that it also depends upon how good the CT analysis is?
Yes,
if it's a dedicated,
yeah,
you know, CT, then you can screen out in our center at least around 70% of patients reliably. But I think, again, you need a dedicated CT analysis, CT acquisition as well. So things have to change a bit.
So I think, sorry, go ahead, please.
Oh, you go ahead.
Okay. So, you know, David mentioned that one of the issues is this sort of issue of lifetime management, Tavr failure. You know, what do we do? Kentaro, do you have any thoughts? Does the discussion of lifetime management or the presence of coronary disease impact your valve selection in the first patient? And if it's a 65-year-old patient versus an 85-year-old, do these factor into your conversations in valve selection or in how you discuss it with the patient?
Thank you very much, Sushil. And actually, according to our Japanese guideline, we usually treat a patient who are older than 75 years old, but we send the patient to Tavr procedure. And if we want to treat the younger patients, we also need to take into account the future coronary access. In terms of that, I think the balloon expandable valve is easier for the coronary access. And if the patient has a really small aortic cannulus, we need to think about having the larger effective orifice area to avoid PPM. And thank you very much, Dr. Park, for the fantastic presentation. And I think the reason for why we Asians have lower incidence of severe PPM is due to less obese patient and the lower body surface area. It's quite rare to find a very obese patient, a Tavr patient in our country. That could be one of the reasons. And as far as we don't have that many obese patients and we don't have that high risk for the severe PPM, we can choose the balloon expandable valve for the future coronary access. Thank you.
Can I ask a question to Kentaro and Dr. Park? And so one of the interesting things in your presentation which struck me was small valve sizes. And the life expectancy in Japan and Korea is very high. So I see that patients who are 75 going for TAVR, before 85 or 85, they're going to come for re-intervention. So what's going to be your strategy? Because they're going to be older, they have smaller valves. So do you think we're burning the bridges already by doing a TAVR before?
So, and first, my thought is about if you consider PPM and seriously, we should consider larger EOA valve and the self-expandable valve. And still, I think PPM is not the fully resolved the issue. There was still largely criticized of a ratio of fallacy. You know, looking at our recent publication and the peak velocity, mean velocity, hemodynamics is much better in Western population. However, if you divide the body surface area and PPM instance is much larger, much higher in the Western population. So I don't know, and still the long-term PPM impact data is lacking, and I fully agree in the PPM should be major determinant of the selection of a valve specific size. That is my opinion.
Can I make one comment? So actually, I was involved in the Japanese guideline committee, and I checked the difference in terms of the life expectancy. Life expectancy at 0 years old is the difference by 3 to 5 years old between Japanese and the Western patient. But the remaining life expectancy at 80 years old is only 1 or 2 years difference between Japanese and the Western patients. So we are not that much different. And if the indication of TAVR is shifting towards younger age, and we need to think about the effective orifice area and avoiding the PPM much more.
And Toro, I was about to move to Japan so I could lose weight and live longer, and now you've just ruined that for us. Thank
you. I have one question to Dr. Tavr. Dr. Tavr, you nicely demonstrated that the small valve in valve and valve procedure is associated with a higher mortality. Then do you have any chance to look at in detail small valve? Why was a small valve associated with higher mortality? PPM itself or associated with the comorbidity?
Well, it's such an important topic to raise. We actually looked at it carefully. The fact that we do not see any significant differences in mortality when we compare patients with elevated gradients and those without elevated gradients is already a clue that it is something in the baseline characteristics of the patients that make them with a worse prognosis, those with smaller valves, those that needed smaller valves. There is a trend for issues related directly to having a small versus a non-small valve, but the majority of the issue relates to the baseline reason that caused the need for a small valve. If I answered your question.
That was great. We're almost out of time. Vinny, I have one last quick question for you. You briefly showed the explant TAVR data from the surgery data with the explanting TAVI valves. It was sort of sobering data, and maybe that's the risk profile of the patients, endocarditis, and you also showed some of the complexities. These surgeries, they need to be concentrated in certain centers, or is this something that you can train other people to do? Because at some point, there are some patients that are going to need surgery. And the data that even in experienced hands, in early experience, was sobering. So what are your thoughts on that?
So we have taken a lot of effort now for the last 4 years to disseminate these techniques. And this is very important. That's the first step. So because, the small differences between explanting a sapien valve versus direct flow versus Lotus when they come back is going to be very different. And if we are not careful, you can suddenly convert a simple explant and a SAVR into a mitral valve injury, which cannot be secured, and it's a double valve. So I think if we reduce those complications, I think the final aim for me is if a patient gets a Tavr explant, it should be like the first time SAVR mortality, morbidity. I think that's the point we want to reach. But that point probably we will reach if the patients are low risk to start with. At present, we are operating on a lot of endocarditis with a lot of reops, elderly patients. I think it reflects the mortality.
So I think we're about out of time, but Danny, one quick 30-second comment. Do you have your hand raised there?
Yeah, it's very short. So the longest time to explant was like 3 years, right, Vinny? In that registry, do you think it's an issue for we are discussing more and more the option of Tavr first? And one of the challenges with Tavr first is the possible need for a surgery after Tavr. Do you think that if we'll do explants 10 years after, 15 years after, that would be even a more significant challenge than the current one?
Yeah, so you are absolutely right. So I have explanted Tavrs up to 6 years. And of course, the endothelial growth is much more, obviously, but not in all the patients. So you have to be more careful, and it can definitely amount to much bigger surgery. And that amounts to Sushil's question is then, yes, I think it should be done by maybe surgeons who do aortic surgery on a routine basis. Because I think we know that already that if we have to do a bigger procedure in these patients, it's just swifter and better, and outcomes will be better.
Thank you. I think, we could talk about this for another 2 hours. I'm sure with this group of panelists, this could go on forever. But we do have to wrap it up. This was a great session, some really important topics. I think one of the takeaways is there's still a lot we have to learn. So each year we're going to need to learn more about lots of different things. So thank my co-moderator, Dr. Young, and all of the speakers and panelists for a wonderful session. Take care, everyone.
Thank you. Thank you.
Have a good day.
Thank you, Cecilia.
Bye.
Thank you.
Nicholas, thank you.
Thank you.
And Taro, thank you.